Welcome to Part 5C, Part C of Week 5. We spent the first 4 weeks learning how to build and query databases. In Parts 5A and B, we covered data manipulation language operations and join operations. Well, now we're going to step back a little bit and look at the big picture. How do all these healthcare databases actually communicate with each other? And this is the world of big data and hopefully interoperability. We'll also examine the major vendors in the electronic health record space who build and maintain these systems, because understanding the vendor landscape is essential to understanding how interoperability works in real practice. As a retired primary care physician who practiced for 50 years, who also holds a PhD in computer science, I have a very jaundiced view of interoperability. Now, I do share the optimism of HIMSS that AI will one day transform healthcare. And to fully appreciate the magnitude of the problem, we need to know several damning statistics. America is rapidly approaching spending 20% of the gross domestic product on healthcare, yet we share the worst outcomes. An African American child born in rural South has a poor chance of surviving their first year of life than a child born in Bangladesh. Europeans now live 7 years longer than Americans. Yes, for rare diseases, American healthcare can be excellent, but routine care is often inaccessible, too expensive, sometimes dangerous, and associated with poor outcomes. So I'm passing the baton on to you, the future health information technology leaders, to solve some of these enigmas. But I want you to be armed with a solid background. By the end of this section, you'll understand not just the technical standards, but the business and regulatory forces that are shaping healthcare data exchange. Think about what we've been doing in weeks 1 through 4. We've been building databases, writing SQL queries, creating tables, learning how to store and retrieve healthcare data. That's foundational work, and it's critically important. But here's the challenge that we must address. There are over 6,000 hospitals in America, and they use hundreds of different information technology systems, whereas there were dozens of electronic health record vendors jockeying for dominance in the electronic health record space. Over the past decade, Epic has clearly emerged as a dominant leader. Although Oracle/Cerner, which is of course supported by Larry Ellison, has significant resources, and just several years ago was awarded a $10 billion Veterans Administration modernization contract. And there's also Athena. Athena Health has a large presence in certain markets, especially ambulatory care and the federally qualified community health centers. So each of those systems has its own database. And you need to understand that Epic is not a relational database. It's hierarchical. Each of these databases have their own schemas, its own way of storing patient information. So when a patient moves from, let's say, South Carolina to New York, or when they see a specialist in a different health system, employed by a different health system, often the data that's possessed by one system is not transferable to another. That's what we call the interoperability challenge. And the solution involves standards, frameworks, things that allow disparate systems to intercommunicate. And that's what we're going to discuss today. Let's start with a formal definition. There it is. Interoperability is the ability of different information systems to exchange, interpret, and use data. Notice all 3 of those components are equally important. Exchange, interpret, and use. It's not enough just to send the data from one system to another. The receiving system has to be able to understand what that data means and to actually do something useful with that data. Now HIMSS, we talked about in the previous slide, the Healthcare Information and Management Systems Society, the dominant professional organization in healthcare informatics, defines 4 potential levels of interoperability, and you can see that on the slide. Level 1 is foundational, which just means you can send data from point A to point B. Level 2 is more structural, meaning the data is in a standardized format that the receiving system can read. Level 3 is semantic, knowledge, which is where we get shared meaning. Both systems understand that a particular code means like type 2 diabetes. And then level 4, the highest level, is total organizational, which involves governance, policy, and trust frameworks. And this is where the TEFCA comes in. We'll discuss that in more depth shortly. So true interoperability requires all 4 levels working together. Why does interoperability matter? Well, here's 6 reasons. First, patient mobility. When a patient moves, their medical records need to follow them. Without interoperability, they're starting from scratch with a new provider who knows nothing about their history and is unable to obtain it electronically. Second, specialist referrals. When your primary care physician refers you to, say, a cardiologist, that cardiologist needs the records, your medications, your allergies, previous test results. And third on the slide is emergency situations. When you show up in an emergency room, let's say you might be unconscious from an accident, the ER needs to be able to know immediately if you're allergic to penicillin, what medicines you're on, are you on blood thinners, what serious diseases you suffer from. Oftentimes that's inaccessible. The 4th bullet, lab results. When Quest Diagnostics runs your blood work, those results need to flow back to your physician, but also potentially to multiple physicians and into your medical record. 5th, the public health reporting. When there's a disease outbreak, possible pandemic, public health agencies need to aggregate data across multiple health systems for surveillance purposes. And 6th, and finally, for research purposes. Clinical research requires data across institutions, which is impossible without achieving interoperability. So what is the problem and what is the solution? Let's say Hospital A uses Epic, but Hospital B uses Oracle Health. And that was the case here in Columbia. It used to be that Palmetto Health was an Oracle shop. But then when Greenville and Prisma merged, Greenville was on Epic. So Palmetto Health switched from Oracle to Epic at a cost of several $100 million. But the laboratory may use some other proprietary system, and the pharmacy yet another vendor. So each of these systems were built independently with their own data structures and schemas, their own formats, their own terminology, their own hardware interconnectability. They literally speak different languages. So the common solution in green there on the slide is standards. If we can adopt some standards, then we should be able to intercommunicate not just bits, but information, data. So HL7, which stands for Health Level 7, and it's not the 7th edition of something. It started out as HL7. It's the 7th level of implementation. It's been around since 1987, and it defines some standards for messaging. Now, FHIR is an outgrowth of the HL7, which is more specific to try to create some standard information that all hospitals and facilities should be able to exchange smoothly. FHIR stands for the Fast Healthcare Interoperability Resources, and it's pronounced FHIR, and it's the modern API-based standard that's rapidly becoming dominant. What is the USCDI? The United States Core Data for Interoperability defines what data elements, what data must be exchangeable. These standards create a common language that allows systems to communicate regardless of who the vendor was. Now, who are the key federal players, agencies? The Office of National Coordinator for Health IT, the ONC, which was recently rebranded and got a new name as the ASTP, the Assistant Secretary for Technology Policy, is responsible for health IT standards and for certification programs and maintaining the USCDI. They're the ones who define what certified EHR technology means. Now, who's CMS? CMS is the one with the checkbook. The Centers for Medicare and Medicaid Services drives interoperability through payment policies. If you want to get paid by Medicare or Medicaid, you have to meet their interoperability requirements. And this has been going on for a long time. Physicians have long learned that if you want to get full reimbursement for your services, you have to meet the meaningful use regulations, which require that you become savvy with electronic health records. And they've been pushing FHIR and APIs heavily for the last several years. Who's HHS? Well, HHS is the Department of Health and Human Services. They oversee the HIPAA privacy and security rules, as well as 42 CFR Part 2, which I'm sure every one of you is familiar with, which governs substance use disorder records. The CDC, the final federal player, the Centers for Disease Control and Prevention, sets requirements for public health reporting, which is a major driver of interoperability for things like immunization registries, disease surveillance, and disease outbreaks. Well, the Institute of Medicine, which has long been an academic and think tank in the area of medical science, which has been rebranded as the National Academy of Medicine, articulated a vision called the Learning Health System. The goal is ambitious. They hope that 90% of clinical decisions should be supported by accurate, timely, and up-to-date clinical information. Think about that. 9 out of 10 clinical decisions informed by the right data at the right time, the right place. Now, I'd like to take just a second and say to a layperson who's not been practicing medicine like I have, you would think that making a diagnosis has some formal, rigid criteria. But too often that's not the case. We don't have formal criteria for making a diagnosis of diabetes or hypertension or Lyme disease. Many diseases, there's laboratory tests that confirm them. But in terms of just the data structures, there is not any standard of what information needs to be obtained to make a diagnosis. We don't have a lot of information about how to assess diagnosis severity. We don't have a lot of support for clinical decision making, clinical decision support systems that can help us manage diseases. We don't have enough outcome data to be able to tell whether our interventions are successful or useful. So I think we are currently living in a primary care data desert. And the goals of the Institute of Medicine or the National Academy of Medicine are wonderful, but I think until we admit that we have a serious problem with unstructured text data in the primary care space, until we turn that into structured data that can be used for clinical decision making, we're going to find ourselves stuck where we are with expensive, dangerous healthcare with poor outcomes. We can do better, but getting the data right is a prerequisite. You can't have artificial intelligence without learning data. And in my opinion, we do not possess the learning data, and we don't possess leaders that are leading us in the direction of obtaining and aggregating this data that will help us practice primary care medicine, point of care medicine with the support of augmented intelligence. My dream is one day we have autonomous care just like we have autonomous vehicles. Well, to achieve the learning health system vision that, as postulated by the Institute of Medicine, there are 5 building blocks as you see on the slide. First, there are the core standards like FHIR and USCDI. Second, there's certification and testing procedures that need to be undertaken to ensure that the EHR systems actually implement the standards in number 1 properly. Third, privacy and security. There's a framework that protects patient data while enabling appropriate sharing of information for research or public health purposes. And fourth, you have business and clinical environments that incentivize data sharing rather than data hoarding. And fifth and finally, the rules of engagement that define who can share what data with whom under what circumstances. That needs to be clarified. Well, let's look at the regulatory timeline just in the last couple of years. In January of 2024, CMS finalized their interoperability and prior auth rule, which requires payers to implement FHIR APIs and streamline the prior authorization process. Now, why is that important? Well, a lot of times a patient will come to their doctor and say, I've got a headache, and the doctor says, oh, you need an MRI, and then they submit a request through the insurance company to find out how much the patient's going to have to pay out of pocket, and then they find out that the insured is going to deny any payment for a test that may cost several $1,000s. So the prior authorization needs to be streamlined, and the patient deserves to get answers quickly, and the appeals process should be much more standardized. Then move along to February of 2024. We saw modifications to 42 CFR Part 2, which governs the mental health substance abuse disorder records. And these new modifications align Part 2 more closely with HIPAA, making it easier to share some substance use disorder treatment information when required. Then move along next to April of 2024, when we had some new HIPAA privacy rule provisions, especially around reproductive health, that went into effect. New protections in the post-Dobbs environment. And finally, in July of 24, the ONC released the HTI-2 proposed rule, which we're going to discuss in detail in the next slide. The HTI stands for the Health Technology Interoperability. And again, the word salad is just going to get worse and worse and worse. There are so many mnemonics, so many names. It's just dizzying. Let's talk about just 2025. Starting in January, the pace continued. We saw the HTI-2 final rule become effective, establishing new certification requirements and interoperability provisions. In August of 2025, we got the HTI-4 final rule, which addressed e-prescribing, electronic prescribing, and prior authorization requirements. Then in November, Oracle Health Information Network achieved designation as a QHIN, a Qualified Health Information Network. And that's very important in that once it's certified, then it means that there's standards about how information can be requested or uploaded or downloaded. So under the TEFCA, this is a big step. This is very significant because it meant one of the 2 largest electronic health record vendors now had its own on-ramp to the National Interoperability Exchange. Then in December of 2025, another busy month, the ONC issued a partial withdrawal of HTI-2. Now think about that. Why do you think that might have happened? We have a new sheriff in town, and they want to reduce regulations. And most of these regulations about interoperability and privacy are long, complex, and Washington's not in the mood to promulgate even more. So we're going to see a little bit of a reduction and a rollback. And so a lot of these proposals that aren't quite in the finalized form, we're going to see them disappear. So they reference the HTI-5 proposed rule, which represents a major new shift towards deregulation. What is the HTI-5 proposed rule? And this just came out 2 months ago. A major deregulation effort, major. The rule proposes removing 34 of the current 60 certification criteria for an electronic health record system. That's more than half of the regulations. The approach is becoming more FHIR focused rather than prescribing specific functionality. The rule emphasizes the ability to exchange data through FHIR APIs. The TEFCA manner exception is being removed, which has implications for how organizations participate in a national health information exchange network. So the ONC estimates that this could save the industry $1.5 billion over 5 years through the reduced compliance burden. Unfortunately, critics worry that removing certification criteria could lead to less consistent electronic health record functionality. So the impact on the compliance landscape is significant and is something we'll need to monitor as it moves through the rulemaking process. What does TEFCA stand for? Well, that's the Trusted Exchange Framework and Common Agreement. Trusted Exchange Framework and Common Agreement. This is the national framework for health information exchange. Think of it as the infrastructure that allows any healthcare provider to share data with any other healthcare provider, regardless of which electronic health record system they are using. The Trusted Exchange Framework and Common Agreement is operated by the Sequoia Project, which serves as the Recognized Coordinating Entity, or RCE. The way it works is through QHINs, Qualified Health Information Networks. These QHINs are like on-ramps to a national highway system for health data interoperability. They connect to each other under a common set of rules and the common agreement, and the goal is ambitious. Any provider should be able to share patient data, either request it or provide it to the network with any other provider who needs it for treatment with appropriate consent and safeguards in place. TEFCA, how does it work? Well, let's walk you through how a TEFCA transaction actually works. Let's say provider A in California needs to get records for a patient who was previously treated by provider B in Florida. Provider A connects to their QHIN, let's call it QHIN A, then QHIN A then queries the TEFCA network, which routes the request to QHIN B. QHIN B receives the records from provider B, then sends them back through the standardized network to provider A. So it's a means of interchange. There are 4 key components to understand here. First, qualified HINs are the qualified health information networks that serve as the on-ramp to the network. Second, the common agreement is a set of rules that all participants agree to follow. Third, query-based exchange allows providers to request patient data when they need it. And fourth, document exchange allows sending clinical documents like CCDAs or FHIR compliant resources legally. The network supports both models, both directions. So who are the designated QHINs as of this moment? As of January of 2026, there are 10 approved designated QHINs. The first wave went live in December of 2023 and included eHealth Exchange, which is a long-established national network. Then Epic joined Epic Nexus, which connects Epic customers. Health Gorilla, which focuses on clinical networks. Kanza and MedAllies, which are regional networks, and Know2, which is a health information service provider. Commonwealth Health Alliance joined in 2024, and then in 2025 we saw eClinicalWorks become a QHIN. Now eClinicalWorks has been in the arena for a long time and is very trusted in the ambulatory care. They weren't a big hospital electronic health record system, but they were big in the ambulatory space, so I was very familiar with that as a primary care physician. Now, SureScripts, the pharmacy network, joined in April, and Oracle Health Information Network achieved that designation just in November. So, the fact that both Epic and Oracle Health now have their own CHINs is very significant. It means the 2 largest EHR vendors have direct on-ramps to the national network, which should accelerate adoption among their customer bases. And it's important for you to understand that for the big systems, the big hospital or healthcare systems, they are rapidly consolidating the dozens of different vendors of electronic health records. They're rapidly coalescing, and Epic and Oracle and Allscripts, maybe a little bit of metadata, but because it's such a complex field and there's so much mergers and acquisitions, it's turning out that almost everyone, most folks are turning to Epic. Some are remaining Oracle, but it's a consolidation phase in EHR space. What is the TEFCA in terms of its growth statistics? Well, now there are over 11,700 organizations live on the network. This means hospitals, practices, labs, pharmacies, and the payers are all online. There are 69,000 unique connections between these organizations. Since December 23, when the first QHINs went live, over 323 million documents have been shared through the network. That's like clinical summaries, lab results, imaging reports, other critical patient information flowing between organizations that previously couldn't easily exchange data. The common agreement is now at version 2.1 that was released just last October, with continued, well, it was released in October 24, with continued refinements to the rules operating the network. TEFCA is rapidly becoming the backbone of a nationwide health information exchange, and understanding it is essential for anyone who's working in this field. So what's the difference between the CMS, Centers for Medicare and Medicaid Services, versus the Office of the ONC approach? These are two parallel federal approaches to interoperability. CMS focuses on payer-provider exchanges. Their requirements are about health plans sharing data with providers and with patients. The technology they mandate is like FHIR APIs. So if you're a Medicare Advantage plan or a Medicaid managed care organization, CMS requires you to implement specific FHIR APIs. Now the ONC and ASTP focus more on the provider-to-provider exchange. Their approach is TEFCA, which supports both legacy formats like the CCDAs and modern FHIR resources. The HDI-2 rule was intended to bridge these approaches, creating a more unified framework. But as we discussed, HDI-5 is now proposing significant changes to put that framework. Healthcare organizations need to understand both approaches because they need to comply with both sets of requirements at the current time. So what's the dual challenge? Here's the practical reality for healthcare providers. They have to support both sets of requirements. On the CMS side, they need to implement the Patient Access API so patients can access their data via FHIR, and the Provider Access API for the payer-to-provider data exchange, and the payer-to-payer API for when patients switch health plans, and the Prior Authorization API to streamline that painful process. And on the ONC and TEFCA side, they need to support query-based exchange for pulling patient records, document-based exchanges for pushing clinical documents, typically CCDAs, and increasingly FHIR-based exchange as that evolves as the standard. So the key message here is that providers must support both. This creates implementation complexity and cost, but it's the current reality of the regulatory landscape. Understanding this dual requirement is essential for anyone implementing or managing health IT systems. Well, let's shift focus now and talk about the EHR vendors. And why does this matter for a course on health IT databases? Because interoperability doesn't happen in abstract, in a vacuum. It happens through electronic health record systems. The vendors who build and maintain these software systems are the ones who implement the standards, and they decide on how the data is stored, how it's structured, and how it can be exchanged. The electronic health record market has been consolidating significantly, so you need to understand the vendor landscape to help you understand the interoperability landscape. When Epic and Oracle Health together control nearly 60%, and I contend it's probably closer to 80% of the acute care market, their implementation decisions have an enormous impact. Understanding who these vendors are, their histories, their approach, their attitude, their strategies, and their current interoperability capabilities is essential context for everything that we are discussing. So let's briefly look at this says that Epic is 37%. I think it's over 50%. Oracle is 21%. It's kind of stuck there because they've spent a lot of time trying to focus on their implementation of the VA system and haven't really been as successful marketing to the existing vertically integrated health systems like hospitals. MEDITECH is slowly declining. It used to be a little bit larger, and that number is coming down as Epic takes more and more of the space. And then there are a couple of others, like Evident and others that we'll talk about, that are out there, but are sort of the smaller players, and we can assume that because of the complexity and expense of the field, there's going to be continued consolidation. And again, Epic has this is ambulatory rather than just the hospital EHRs. Again, the same big players, although Athena Health now enters the equation. Let's talk a little bit in more depth about Epic. Let's go through their history. It was founded way back in 1979, the same year as Cerner. I got my MD and PhD in 1975, so I was around when Epic was just starting. The founder, Judy Faulkner, she remains the CEO even though she's 82 years old. Pretty remarkable. And the company, which is headquartered in Wisconsin, a very interesting site. They have training exercises there, and they call it like Disneyland or Alice in Wonderland. They try to make, when you go there for a training exercise, they try to make it very entertaining and enjoyable. So Epic systems now cover 325 million patients, and they're a little bit worldwide, but some of the smaller players actually have a bigger presence in Europe than Epic. Epic, because it's so expensive and so large, has not really penetrated the European market. They don't have the funds to be able to afford the Cadillac system. Epic has over 14,000 employees. Last year they made, and back in 2022, their revenue was reported at $5.7 billion. So we spend a lot of money on electronic health records to accumulate information. The question is it of value? Is that information really what we need? A lot of my research suggests that it's not, but that's a topic for another lecture. But what's particularly notable is that Epic is privately held, so it's not under the scrutiny of shareholders or the government. It's never taken a penny of venture capital. It's all been self-funded. Interestingly, Judy Faulkner, we'll go through her history a little bit more, but she had a wonderful relationship with the first hospital that she automated, and they funded a lot of her development, but allowed her to have the intellectual property rights, and so she was able to grow the business. And some of the founding efforts were subsidized by the hospitals that she automated. She earned her master's degree in computer science from the University of Wisconsin there in Madison, and she started Epic in her basement. She had about $70,000 from friends and family and investors. What inspired her to focus on healthcare? Well, she took a course of computing and medicine that opened her eyes to the possibilities. But she also had a lot of support from her husband, who happened to be a pediatrician. And so he actually lost a patient who had moved to a different city and the records didn't follow the patient, and critical information was unavailable. The tragedy drove Epic's interoperability focus from the outset. Faulkner has rejected a $30 billion buyout back in 2025, choosing instead to keep Epic independent. She also signed a giving pledge committing to give 99% of her wealth to charity upon her death. Her long-term perspective and mission-driven approach have shaped Epic's culture and strategy since the outset. So what are some key features of Epic? Well, they have the Care Anywhere Foundation, which is the health information exchange software that interconnects the Epic sites. The Epic Care Link extends this by providing a portal for non-Epic providers to access data from Epic systems. Epic Nexus is their designated QHIN for TEFCA, giving the Epic customers direct access to the national network. MyChart is their patient portal with over 300 million users. It's one of the largest patient-facing IT platforms in the world, but as a user of that system, I find it less than friendly trying to get messages to the doctor or getting results back or finding out what your diagnoses or medicines are. Sometimes you can get reports fairly rapidly, but your access to the record is very restricted. Epic has 160 to 200 AI projects in development, kind of saying that they have an interest in the emerging technology, but in my opinion, when you have most of the outpatient, most of the primary care information they have is unstructured text, it's going to be very difficult for that to be converted into useful knowledge for artificial intelligence. Who are some of the key clients? One of the ways that Epic has really increased consolidation in the industry is over the last 6 or 7 years, they have a list of the most trusted users like the Mayo Clinic, the Cleveland Clinic, Johns Hopkins, Kaiser Permanente, Massachusetts General, Peter Bent Brigham, Harvard, UC, the University of California Health. So they have all the big players, and by having those, when medium-sized or smaller hospitals are looking to decide which vendor to use, the fact that almost all of the huge prestigious academic centers are using Epic gives them a step up. Even Kaiser, which is usually tries to be fairly cost conscious, and they also have a lot of in-house IT capability, they signed with Epic back in 2003 with a deal first that had 30 hospitals and 11,000 physicians, but that was kind of a watershed moment that validated Epic's position in the industry. So the pattern here is that the most prestigious, most complex health systems in the country have pretty much all chosen Epic, and this creates kind of a cycle where other organizations feel safer choosing Epic because the big guys, the big boys already have. Now, what's the status with Oracle? Used to be Cerner. It dates all the way back to 1979, just like the others. But the big news is that Oracle bought Cerner for $28 billion in 2022, just a few years ago. And this is one of the largest healthcare information technology acquisitions ever. And their flagship product is called Cerner Millennium, which was launched in 1997 and remains their core platform. Their combined organization boasts 28,000 employees, and they have a significant presence outside the United States, more than Epic does. Epic is pretty much mostly American. I think some of the things that you need to be aware of and take into account about Cerner is Larry Faulkner, who owns is the largest stockholder in Oracle, is someone to be reckoned with. I mean, he's even though Oracle's position has diminished some, the VA contract that he has and some of the things that they're doing in artificial intelligence, I wouldn't count them out. I think they're going to rebound. They're going to bounce back. The initial founders were a group of CPAs. They all worked at Arthur Andersen. They had a client that was in the pathology business, and so they helped them with their electronic billing, and it just grew. The name Cerner comes from Latin cernere, to discern. It went through an IPO in 1986, so it was publicly traded. But then when Oracle came along to buy Cerner, this stock changed hands. They also have a strong presence in Kansas City. They have some of the sports teams, so they're a community-focused player. What are some of the key features? Well, the Oracle Health Information Network, it's been approved as a QHIN, so they've gone through the work to get certified, and that's a big step. So it allows them to join and receive, both share and receive data in this standard format that will help them grow and prosper and relate to users in non-Oracle shops. The Millennium platform remains the core of their electronic health record with thousands of implementations worldwide. Like I said, they have a bigger presence in Europe than Epic. And so I think that says something about their longevity and their growth prospects. And artificial intelligence integration has been a major focus. So with all the processing power of Oracle, I have a lot of confidence that Oracle Health will be able to enter the AI space and doing things like voice technology and a lot of innovative things that are going to be a little bit more difficult for Epic. One of the things that Epic did that we didn't talk about before is Microsoft bought for $19 billion a software product that called the DAX, the Dragon Ambient Experience, which is a product to allow primary care physicians to offload a lot of the documentation effort for the encounter by just having a smartphone record the conversation and be able to use artificial intelligence to resequence the questions and answers and put them into a format that's easy to download into the electronic health record, alleviating the primary care physicians of a lot of the burnout that results from having to dictate the history and physical and assessment and plans. So like I said, Microsoft bought that, but they've now incorporated that into Epic, and I'm not sure whether they've gotten it also merged as a capability in Oracle Health, but we're going to see ambient listening technology as a major driver for electronic health records in the primary care community. And we talked about the VA contract, which was $10 billion. And they also have a $4 billion contract with the Department of Defense to try to automate the health records of the veterans and active duty service. So I think those are some things that give Oracle some stability and a brighter future. When Oracle acquired Cerner, it had a lot of impact. It was, like we said, $28 billion, and there have been some major CEO leadership changes. But one of the things that they did do was they hired the former CMS administrator to become the executive vice president and general manager for health. And so that means we have somebody that kind of knows the government side, and I think that's going to be helpful as we go forward. They've also moved from the Kansas City area where they were really dominant, a major player economically, but they're now in Austin, Texas, So I think that'll involve some transitions. So whether this acquisition ultimately helps or hurts Oracle Health's position in the market is still uncertain. It still remains to be seen. But integration at this scale, when you're talking about billions and billions, I mean $28 billion, it's monumental. MEDITECH is a smaller player, although it's been around for a long time, but it's it has a fairly interesting history, and the readers are welcome to look at it. But I think with the consolidation that's going on, we're seeing the smaller players being squeezed. MEDITECH had a bigger position in some of the smaller hospitals, so they have always had a mission to try to make technology affordable in all communities. So they have some loyal following there. So their latest product was introduced in 2018, so they're still doing development and introducing new modules. But like I said, the market is getting so concentrated. I have concerns as to what their viability is. What has Meditech done about the transfer, the interoperability? Well, in the third quarter of 2024, they they introduced their FHIR first private interoperability network, meaning it's built on the modern standards from the ground up. It's compatible. So there are over 600 facilities in the United States that are now connected through Traverse for their TEFCA access. And Meditech connects through the Health Gorilla, one of the designated QHINs. So they're compatible and they're meeting the regulatory requirements. So Meditech was recognized by Black Book Research as the #1 EHR for community hospitals, for small hospitals, even as recently as 2025. So I think this reconfirms their continued strength in a niche market. But unfortunately, that niche keeps getting bought up by health systems, and then they lose their contract. So we need to figure out what the viability of a small community hospital is, not what the viability of Meditech is. And then here's a list of some other vendors that are also RANs that you should have some familiarity with. I have some personal experience with Athena Health, and they are a wonderful group of people to work with. And they also are the biggest player in a niche market of federally qualified health centers, the community health centers. These are about 15% of all the healthcare in America is delivered through community health centers, which are places that cannot refuse care based on a patient's ability to pay. They have a lot of indigent care, a lot of Medicare, a lot of Medicaid. So we have a large one here in Columbia, Cooperative Health, and I've worked with them for 30 years. And they use Athena, and I used Athena through them. So I think Athena has a future. They're very innovative. They're lean and forward-looking. And the other one that you should be aware of is eClinicalWorks. They've been around a long time working with smaller private practices, but then as the hospitals bought up those practices, they kind of lost their user base, but they're still there and they're doing some interesting, innovative things. They're trying to stay relevant, and I would not count them out either. There are also some specialty vendors in certain areas, like there's certain specialties that have evolved kind of their own products, and they maintain them. Some of them were gobbled up by some of by the national vendors, but several of these are worth your looking into a little bit for specific areas to learn a little bit about what their products are, how they're distinguished from others, and what their viability is as the consolidation progresses forward. In terms of interoperability, which is the focus of this part of the 5th week, the Epic, of course, has its Epic Nexus for which is a QHIN approved. Oracle got on the bandwagon even before Epic Nexus was approved back in November. MEDITECH does their interoperability through the Health Gorilla. And eClinicalWorks has invested enough to have their own QHIN status that happened about a year ago. And Athena Health just goes through the FHIR, but they're compatible and they're very experienced at that also. We talked about the market consolidation, which I think is going to have a huge impact on the future. The Epic dominance continues to grow. I mean, it's growing fast. The Oracle acquisition, I think that Larry Ellison will keep Oracle pertinent, relevant. The small vendor challenges, unfortunately, so many of the small vendors get bought up by hospital systems. And so even though they have a loyal following and the users are not unhappy, when they get bought up by the bigger systems, they don't get a choice as to who's going to be their electronic health record. And of course, all of the major vendors have moved to the cloud, so that's not an issue that's going to differentiate among the various users. And then the last thing we want to talk about is the artificial intelligence race. We all hear how artificial intelligence is going to change everything. I mean, there was to say that 70% of current jobs, especially the simple, even things like lawyers and accountants, people say that artificial intelligence is going to replace a lot of those jobs. In healthcare, I think we're not immune to some consolidation. So every one of these vendors is looking at the AI space, but I really think that, in my personal opinion, artificial intelligence cannot happen without learning data. And I think the data, the way we capture it in healthcare, is really not amenable to consolidation to form the learning data for artificial intelligence. So I think in order to harness artificial intelligence, my opinion is we're going to see some revolutions. We're going to see some upstarts that have a product that, maybe Epic or Oracle will purchase or merge into their system, but the philosophy that they're using now is not compatible with the rapid transition to artificial intelligence. We do not capture enough data, enough structured data to use the electronic health record for clinical decision support. So for an organization that's considering a change in their electronic health record, there are many issues that they need to consider. The most important ones are these 6, but I think what's happening now, because Epic is kind of the gorilla in the room, the elephant, it's very hard to compete against them unless you're in specific niches. The interoperability is awash. They're all able to do that. The cloud readiness, they're all doing that. They all focus on trying to give great customer support. Interoperability has kind of been leveled. The playing field there is leveled. So clearly Epic is more expensive, so budget's a consideration. And specialty needs, sometimes if you're in a certain specialty that has a dominant vendor, you're going to try to stay with them as it's part of your environment. And what about the database implications? Do they have relational databases or are they hierarchical? The schema design, each vendor has different models. What about the APIs for the FHIR API, REST APIs? How do you query data programmatically? What's the focus? What is the ease of interoperability? Are they compliant with the existing standards like the USCDI, the core that's still coming out and looks like they're pulling back from implementing forcefully some of that? But the FHIR profiles have been around long enough; they're going to be important. But all the vendors have the capability of implementing that. So when we look at our specific example, our X-Health, we are trying to capture the data in a structured format that will support artificial intelligence. So stay tuned. I think you're going to find that we are, with X-Health, our database is looking at each disease as a way to come up with criteria for quantitative confirmation of diseases, for measuring disease severity, for looking at potential outcomes and monitoring diseases, multiple chronic conditions over a long period of time. So working with providers, with patients, with labs, getting all the information about encounters. But the main thing is we want to get down to the elements of the symptoms, not just diagnoses. So we want to get down to the minutia, much more structured data, much more data, but hopefully developed and gathered and accumulated in a format that does not add to the burden of the primary care physicians who are already suffering from burnout from all the data that they have to face and try to insert into the electronic health record. All right, so this brings us to the end of week 5, part C. In part D, we're going to dive a little bit deeper into the USCDI and the US core and your skills. Your database skills will come into play when you understand how these standards map to the actual database tables. The SQL that you've been learning and writing queries are the same types of data that the USCDI defines and the US core structures. So our next part, part 5D, we'll talk in detail about those. So let's summarize what we've learned today. We've talked about TEFCA, providing a national framework. We talked about the 11 existing QHINs with over 300 million documents in the network, transferring through the network. We talked about the government's role, both CMS, HHS, CDC, ONC. All their approaches are all converging. We're trying to come up with a national framework. We need to be compatible with those. So the regulatory landscape is certainly evolving. And then we talked about all the existing EHR vendors. The biggest one, of course, is Epic. Oracle's declining in its market share, but is I think viable. Those are the two that we'll need to be looking at carefully as the market unfolds. But the key thing with the EHR vendors right now is trying to crack the interoperability nut. That's the competitive differentiator between systems. They're all focused on trying to make it easier and easier to do the FHIR or the HTI, whichever interoperability, whether they can use the QHINs. They're all developing capabilities that are making it easy for their data to exchange with the patients, and interoperability among systems. They're all focused on solving that same problem with the same passion, same vigor, same investment. So we will see interoperability solved. So as we go into week 5, part D, like I said, we'll go into a deeper dive on the USCDI, what data elements must be exchangeable, how USCDI maps to FHIR, and trying to integrate everything together with SQL, standards, and interoperability.